Thank you for joining us for the second of two sessions entitled Supporting Students Returning to School After Psychiatric Hospitalization. We have with us Dr. Laura Henderson-Smith, who's presenting. I'm Elaine Densley. For those of you who don't know me, I think most of you do. I serve as the Administrative and Program Manager for the Virginia Tech Richmond Center, and we are providing the virtual conference management today. So this is a Zoom meeting. It is a small meeting. Please feel free to raise your hand, unmute yourself, ask questions as you will. There are no scheduled breaks over the next hour and a half, but so feel free to get up as you need to. Thank you. Oops, a second. Sorry, I have to do two jobs. So we hope that you found part one of the training informative and engaging. In part two, Dr. Henderson-Smith will delve deeper into the strategies and tools that can make a significant impact on our students' well-being. Your active participation and engagement are key, so don't hesitate to ask questions, share your thoughts, and make the most of this learning experience. Let's welcome Dr. Smith to the floor.
All right. Hi, everyone. It's good to see you all again and glad to have you here. Let me start sharing my screen. All right, so like Elaine just said, this is part two of the workshop on school reentry after psychiatric hospitalization. To kick it off, just want to go through the agenda. I'm going to do some quick introductions again. I'll just quickly go a bit through youth mental health and some things I didn't cover last time and things I want to make sure that we highlight. Do a school reentry overview, and then really dive into best practices in school reentry. There'll be a couple activities in there, one activity around resource mapping, and then one on action planning at the end. We'll save some time at the end for Q&A, but also, like Elaine said, feel free to jump in and ask any questions, provide any comments throughout. Looks like we got a small group. Hopefully we'll have some more folks logging on, but if not, totally fine. Please feel free to engage and jump in as needed or as you so desire throughout the presentation. So as we kick it off, you guys could just start off with name, role, and then answering one of the questions. So either what was your key takeaway from last week's session, or what do you absolutely want to make sure that we cover today? Doesn't look like we have any new folks, so the second question there is irrelevant. I see L. Gaskins first. If you can tell us name, role, and answer either what was your key takeaway or what do you absolutely want to make sure that we cover today?
Yes, I'm having trouble with my camera.
No worries.
So anyway, yes, I am Lori Gaskins. I'm the clinical coordinator, LPC, with the Children's Crisis Home at in Windsor, Virginia, with Western Tidewater Community Services Board. I really enjoyed the session last week, but I'm especially looking forward to this week to getting to know or learning more interventions that I can share with my team. That's what I'm looking forward to.
Awesome. Thank you. Daniela, I see you next. I know you're just sitting down to eat, so hopefully I caught you before you put a bite in your mouth.
Hi all, this is Daniela Taylor. I'm one of the clinical supervisors for the Therapeutic Day Treatment Program at RBHA. We're currently in 25 schools across Richmond City between elementary, middle, and high. And typically, if we have a client discharging, they're more on the middle or high school level. So just seeking more information that I can take back to my staff.
Awesome. Thank you. All right. Next, I see Dougie.
Okay, I'm Dougie from RBHA. I'm a clinician and intensive care coordinator. One thing I learned from last week is communication, collaboration with the school and other providers.
Perfect. Thank you. And Sheree?
Hi, yes, Sheree Thompson, Child and Family Case Manager with RBHA. Interested in learning, continuing the collaboration between the school and the community and the families and bridging that gap between hospitalizations and going back to school. So, yeah.
Awesome. Thank you. Well, it looks like we've got a small group today, so I can't say enough. Feel free to kind of jump in and ask questions or provide comments throughout. I'm totally okay with that. I'm often presenting to folks who are school mental health professionals, and all of you work in the community or in schools, but not for the district, it sounds like. So I'll be particularly interested in kind of how these concepts resonate with you. I imagine that they'll be important in your roles and also important for sharing with the folks in schools too. All right. So just a quick recap on youth mental health statistics, things you already know. In 2021, the U.S. Surgeon General declared a youth mental health crisis, exacerbated by COVID-19 globally and in the U.S. and locally in Virginia. There was an increase in youth depression and anxiety. Depression doubled. Depression and anxiety both doubled, with 1/4 of youth experiencing depression and 1/5 of youth experiencing anxiety. I know we're talking about youth, but this increase in depression and anxiety has also been seen in adults too. And more recently, there was, I think the Surgeon General declared a crisis of social isolation that kind of came from the pandemic as well, that's impacting adults and not just youth. So as we think about youth and their mental health and their experiences in schools, it's always important to also think about the adults and ourselves and our mental health and what we're experiencing, since we are living in the same culture or same climate and experiencing the same cultural things that our youth are experiencing. We talked last week about the increase in emergency department visits that was really significant for girls and Black boys as well. Talked about how this is national and in Virginia. One thing that I did want to point out is I had this image here last week, but I didn't really speak to it. So this image highlights that the majority of Virginia is a mental health shortage service area. So the dark blue, which is virtually the whole state, is a mental health shortage area. There are only a few areas where our kids have access to the mental health services that they need. Obviously, schools cannot fill that gap alone, but schools are a place where our kids are every day, except for in the summer. Some of them are there over the summer too. But you want to really think about the role that schools can play in supporting youth mental health. The governor is aware of the role of schools in youth mental health. You can see that this is a continuum of behavioral health care in Virginia that was proposed by the governor's Right Help Right Now plan. They have schools and colleges meeting the needs of students pre-crisis and providing pre-crisis prevention services, but all of us here know, you can see the little schools that I added there, that schools are really doing prevention, but also doing crisis care and post-crisis recovery and support, which is what we're talking about with hospital to school transition. So schools are a really important place for us to meet the needs of kids returning to school. When they're discharged, they are expected to return right back to school immediately. For some kids, that's returning for the full day. For other kids, it's having a more abbreviated day, or maybe they need some homebound time. But in general, schools are the place that kids are always going back to. Maybe they've been connected with community services. Maybe they have a community mental health provider or private practice, but we can always count on kids going back to school. So really important for our school mental health professionals, teachers, and administrators to be prepared to meet the needs of these kids and their families as well. Just further highlighting the importance of robust school mental health services, and particularly around hospital to school transition. Many youth receive school mental health services only, about 30% of youth. 60% of youth receive school mental health services, 60% of youth who receive any type of mental health service. receive services inside and outside of school, which is a really large amount. 60% is pretty good. But youth who are more likely to only receive services in school are those who have public insurance, those from low-income backgrounds, and those from racially and ethnically minoritized communities. So it's also really important to think about equity in terms of school mental health services and how school might be particularly poised to meet the needs of these kids with some additional needs. All right, so now we're going to get into some strategies to support students before, during, and after emergency department visits and hospitalizations. Last week, we talked really big picture, and today we're going to get into some of the details around the multi-tiered system of support and how different interventions can be implemented to prevent and then address and respond to these crises. I do want to note that across Tier 1, Tier 2, and Tier 3, there are very few evidence-based interventions for hospital to school transition specifically. So a lot of these recommendations pull from the literature on supporting students with suicidal ideation in schools or from the suicide prevention literature. So this is a growing area that needs more work, but there are definitely things that we can pull from other fields and other issues that can support these kiddos. So when we're talking about hospital to school transition, as I said last week, we're often talking about the Tier 3 kids. This is particularly true given that for many kids, the first point of entry into the mental health system or into receiving mental health interventions takes place in the emergency department. So unfortunately, for a lot of kids, we don't get to do the Tier 1 universal screening or provide Tier 2 supports to help keep them out of the emergency department or the hospital, but it's still really important to be thinking about what can be done at Tier 1 or Tier 2, while also acknowledging that for a lot of kids, half of them, we won't have that opportunity. So I'm gonna go over the strategies I shared last week, and then I've got specific slides on each one of these that digs in more. So for Tier 1, we're looking at training and professional development for all staff to increase mental health literacy. So at Tier 1, we're really wanting teachers to be able to help identify kids who are having mental health challenges and then get them triaged to a school social worker, school counselor, school psychologist, or someone else who can help. We're not expecting teachers to be providing robust counseling services in the classroom, but we want them to have some mental health literacy and to know who to go to within their school building or community for additional support. Also at Tier 1, we're looking at programs that support student well-being. So this is your typical social emotional learning curricula that are implemented in schools. Some schools have other Tier 1 mental health literacy programs for youth, but in general, whatever Tier 1 programs that are being done to support student well-being and social emotional learning are helping with hospital to school transition and hopefully doing some prevention. They're just things that are good practice that are providing prevention services for students. Also at Tier 1, we are having administrators and school mental health professionals and those who might be involved in the transition process to develop protocols. We're having some universal mental health screening for students and then doing resource mapping. So we will get into each one of those. So in terms of school staff training, there are a lot of different options. Mental health first aid is a popular one that's been used not just in schools, but in community organizations, on college campuses, and across the board to just provide some basic mental health literacy. There are other mental health literacy trainings as well. If you're interested in those, I can share some literature. With mental health first aid, you have to pay a trained person to come in and implement the training. You can also have someone from your organization get trained if you think it's something that's important in terms of increasing sustainability, to have someone in-house who can do that. But there's a cost to that. The National Center for School Mental Health, which I'm going to reference a lot throughout today's presentation, has an online training called Classroom Wise. And this is a training that teachers, school mental health professionals, anyone can do to gain some basic mental health literacy training. It's online, it's asynchronous, so you can kind of go through it at your own leisure or recommend it to teachers to have them go through at their own leisure, or ideally during some designated professional development time, so that we're not just adding more work onto everybody's plate. One of the interventions that is actually evidence-based is the ASSIST training, Applied Suicide Intervention Skills Training. Again, that's one that you have to have a trainer come in and do it and pay for it, but it's one that is a good tier 1 training for suicide prevention and intervention in schools. Also, training around homeschool community partnership is great. Really important at tier 1 for hospital to school transition, because you get kids at tier 3 who have been hospitalized and they don't already have a good connection between home and school. Then the communication and collaboration to support them as they return is really, really difficult. So always important to make sure that school staff understand the importance and are receiving training on homeschool and community partnerships and what that looks like culturally and contextually across different communities. And then lastly, training or just sharing knowledge around trauma-informed practices and making sure that teachers are engaging in trauma-informed practices in their classrooms, their families, and just more broadly in the schools. So these are all tier 1 considerations for teachers, school mental health professionals, the broader school community. So some tier 1 student programs. Again, with the hospital to school transition literature, there aren't any evidence-based interventions that are specifically getting at hospital to school transition, but there's a lot of overlap with the suicide literature. So some interventions or some tier 1 programs that have been found to be effective are directing change, signs of suicide, and sources of strength. If you want to know more about any of those, or if you need to provide some literature on any of those, please let me know. Signs of suicide includes suicide screening and some lessons around suicide prevention, and sources of strength does as well. For directing change, it's actually a video contest, or it's suicide prevention disguised as a video contest where youth are given some specific instructions about needing to make a video about suicide prevention that includes like this information, and this information, and then they create their videos, and those videos are shared across the school community, and students like vote on the best one, and there's a whole contest around it. But the idea is that the kids who are creating the videos and engaging with the project are learning about suicide prevention, and then throughout the distribution of the videos and the voting, other kids in the school are learning about suicide prevention as well. So it's not just staying with the kids who are participating, but it's really providing information more broadly across the school community. Also, like I mentioned before, social emotional learning curricula can be helpful prevention tools as well, as kids learn about self-management, social awareness, and self-awareness, and things that are important in terms of being able to monitor and get support for their mental health. At tier 1, it's where you want to be thinking about developing that transition protocol, because once you get to tier 2 or tier 3, it already needs to be in place. These are typically administrators and school mental health professionals who are involved in this at tier 1. And so it involves developing a transition team, which we talked some about last week, and often includes administrators, school mental health professionals, maybe a special education teacher, case manager, typically folks who are within the school. So at this stage, you're reviewing formal transition plans and processes, or formalizing informal plans. So there are a lot of schools who have their informal practices, but if that school counselor that leads the process were to leave, or if that administrator were to leave, then people wouldn't quite be sure what happens during that process. So this is kind of writing down the informal process, or looking at some formal transition plans and developing a plan or process for your school. The whole idea here is that there are different protocols and different procedures, but it's likely that your school community needs one that is specific to meeting the needs of kids and families in your area. They typically include some details about communication, a school reentry meeting, and documentation such as the school reentry protocol document. I'll be sharing one of those. Safety planning, makeup work, those types of things. But at tier 1, you want to know exactly what your protocol is for kids returning to school. Universal screening is another good tier 1 approach. This one is evidence-based, not specifically for hospital to school transition, but just in general for supporting student mental health. There are a number of tier 1 universal screeners for supporting student mental health. And the National Center for School Mental Health, again, has a resource called the SHAPE system that you can use to, it's a free online platform that you can use to see what might be appropriate for your school. Some things to consider are if it's reliable, is it evidence-based, is it free, or does it have to be purchased? A lot of the ones that they have are free or low resource. Sometimes people are also considering how long does it take to administer or score. So people may want something that teachers can complete pretty quickly, or people may want something where there are multiple reporters, where you're getting a teacher report and a student report. So there are a lot of different factors to consider around universal screening. The biggest concern that I hear around universal screening is that folks want to implement it, but then they're worried about kind of the legal implications and what you do if you find out that a student has significant mental health concerns that can't be met. And so it's really important to kind of talk about those things as a team and identify resources within the school, as well as community resources that can be used to help meet student mental health needs that might be identified at tier 1. And obviously identifying needs at tier 1 is best case scenario and will hopefully help kids not advance to tier 2 or tier 3, or will help us identify those tier 2 kids before they get to tier 3 as well. So really a nice tool for the prevention of future emergency department visits and hospitalizations. And there's a handout that Elaine will share that has links to all of the different resources and websites that I'm talking about. So I hope that you find that helpful. And so I mentioned that with universal screening, it's great to be able to identify resources within the school and in the community that can support student mental health. So another really important tier 1 tool or practice to engage in is resource mapping. So resource maps are living documents that detail the school's internal and external supports and the internal and external supports available to students and families. And they can be mapped across multi-tiered systems of support if desired. To be able to successfully create a resource map, you have to be able to identify what are the services that are provided in school, what's working, what's not working, where are there gaps in services. So maybe there's something that a need that the school can't meet, but are there community resources that are available? So it really helps you to identify the strengths of the school and community assets as well. There are different categories that can be included in these resource maps. So maybe a crisis hotline, or maybe housing resources, day treatment programs, mobile crisis teams. Not going to read them all here, but you can see them, and we're going to come back to this with an activity. I guess the ones that probably be most relevant to the work we're doing are the mental health services, school-based mental health services, inpatient programs, emergency room departments, mobile crisis. A lot of them are relevant, but it doesn't just have to be around mental health. It can also be about other community needs, such as support groups for parents or food resources for families who might be experiencing food insecurity. So this is just an example of a completed resource map. And so it's identifying some resources inside the school. So that includes the school psychologist, the school social worker, outpatient success services. And then it kind of identifies what these people do, when they're available, the best way to reach them, and who they can serve. And so this is a document where you might have a version that you share with families so that they know who they can reach out to. There may be an internal document that has some additional information for teachers, but this is a document that can be very flexible Just the main thing is that it should have the resources needed and that it should be a living document, because often these things change. And so I highlighted the inside the school resources. And their example here is outside of school, Boys and Girls Club as an after school enrichment program. And so sometimes you make one of these and then the program ends, or you hear not so great things about a program and kind of want to remove that as a recommendation. So really want to make sure as you create resource maps that you're constantly kind of revisiting them and updating them based on new information. I was working with one school district that actually had their resource map in a Google, like a Google document that anybody could access via the link, but only a few specific people could edit. But it made it really easy to have it being like a live working document that they could update often. This is just another example of a template for developing a resource map. So this just has different categories of like on-site resources, who's the school psychologist, counselor, IP coordinators, are there university or community partner agencies, things like that. And then in terms of community resources, they have like mental health clinics, psychiatrists, social workers, psychologists. So this can be really nice for families who need some mental health supports and don't know exactly where to start. As you get into the details of these, you might highlight mental health clinics or psychiatrists or social workers in the community who take insurance, those who don't, those who take Medicaid. A lot of that really detailed information can be helpful for families. This is just another example template, whereas like eligibility requirements and how to enroll. Don't need to look at these in detail, just showing you some different examples of how this can be done. Another one, like a resource information sheet, where it looks at insurance is accepted, is it near public transportation, are there bilingual staff available, just all kinds of different considerations for including on a resource map. So again, no expectation that you do each one of these, but just sharing some different examples of what you might include. So at this point, I'm going to do an individual activity for about 10 minutes where I want you to look at the categories of the resources that you would like to map. Pick 3 categories that you want to, 3 categories that you want to include on a resource map related to supporting students returning to school after hospitalization or emergency department. And then identify resources within the school to support these students. Identify resources outside of the school, and then if you have time, start to collect contact information for those resources, and then note any areas where additional supports are needed or who you can and think about who you can consult with for additional support. So we can take about 10 minutes for that. I am obviously here. I'm also going to be thinking about this for my community here in Charlottesville. So please feel free as you work on this to unmute and ask me any questions if you'd like. But I figured it made the most sense to do this activity individually instead of in a group. So if there are any questions, please let me know. Or if not, you can get started. I'm going to set a timer for 10 minutes and then we will come back together. Thank you for engaging in that activity. I would love to kind of hear any reflections or things that came up for folks as you were working on that. I can share a few things that came up for me as I was identifying community resources. I looked at crisis hotlines, emergency departments, and mobile crisis teams. And so I realized that I identified like the national hotlines, like the National Suicide Prevention Line and the crisis text line. But then I realized that Region 10 has an emergency services number that can be used, and that there's also a helpline through UVA. But UVA's helpline is only run by students. So in sharing that with families, it would be, well, it's run by students only during the school year. So in sharing that with families, I'd want to highlight that over the summer, that service is not available. So there was that piece of nuance that I came across. And then also, as I was looking at our emergency departments, we have three. We have UVA, Centara, Martha Jefferson, and then Centara has a standalone emergency department. But none of those three offer any inpatient services for youth at all. And then only UVA has adult inpatient. So in working with families, if I were to be sending a child to be evaluated at the emergency department, I'd likely want to send them to UVA where they have children's services. Because if I sent them to Centara Prophet Road, they'd probably definitely be transferred and the family would incur an additional cost. So some of these like types of nuances could be really helpful to provide to families on a resource map. We also have mobile crisis, just standard mobile crisis, and then there's a reach crisis program for individuals with developmental disabilities. But wondering if anybody else noticed any interesting things or nuances, or if you had a hard time finding something.
I think I struggled with, like number 2 says, identifying the resources within the school.
Mm-hmm.
I struggled with that.
Yeah, that's a tough one. Often it's just a school psychologist or school counselor, school social worker. Sometimes there are people in those roles who are particularly well trained or suited for this, but often it's just those 3 people who have a number of other things on their plate and not just hospital to school transition. I don't know if others had thoughts on the folks within the school.
I will say Richmond Public Schools is becoming better with offering in-school supports, because I would agree with you. Previously, like you said, it would be the school social worker, the counseling team or guidance counselors, the psychologists. Now Richmond has branched out. Not only do they have TDT providers within the school, they have child savers providing outpatient therapy within the schools.
Nice.
They have identified it's a school-based mental health team at each school, and they meet once monthly to identify any students who are in need, and then they determine whether maybe it's TDT appropriate, more of an outpatient scenario, and things of that nature.
Nice.
We're taking it a step further. We have grant funds now where RBHA has school-based clinicians. And because we're partnered with RPS, they will tell us which school sites they need those clinicians at. And that clinician is solely completing intakes and providing outpatient. So currently we do have another clinician that needs to be placed, but we're waiting on RPS to let us know what school would benefit from that, because some schools already have services in place.
That's awesome that Richmond Public Schools is doing all of that. Also made me think about here in Charlottesville, Albemarle Schools has like a contract with a national, it might be the National Counseling Agency, to provide some virtual mental health supports and outpatient therapy within the school building. And then we also have I think they're called SEED counselors. I don't remember what that stands for. But these folks who are kind of meeting the needs of students who have some mental health needs or behavioral needs, but don't qualify for an IEP. So these kids who have often kind of fallen between the cracks. I do think that might be grant funded also. So hopefully it's something that they'll be able to write into the budget or continue in the future. But it's definitely a step towards meeting students' mental health needs.
Absolutely. And I'll share too, when I went to a staff meeting last month at one of my schools, the school social worker was sharing how, the process for referrals, for teachers to refer to her, but she had also mentioned that she was only allowed to have 5 kids on her caseload
Wow.
at any given point. And I'm thinking, I believe that school has an enrollment of maybe 300 or more. And I'm thinking 5, you can't, you can barely reach, the student population if you're capped at 5. So yeah, some barriers are there.
For sure, for sure. That sounds like things are moving in the right direction, hopefully, and that we can work towards getting some of those barriers addressed. All right. Well, I hope that resource mapping activity was a helpful start for you all. Perhaps your organization already has a resource map that can be updated or improved upon, or maybe you're just getting started on this process, but can be really nice to have as a tool to turn to when you need to make a referral or recommendation, or to be able to share with families. So it was helpful for me. I hope it was helpful for you as well. Now we're going to move into tier 2 strategies. So tier 2 is where we're thinking about targeted training and professional development for the school mental health professionals, administrators, and others who are actually involved in hospital to school transition. We're also looking here at the tier 2 programs and small group interventions for students who have been identified as at risk for mental health concerns. This is also where suicide screening and safety planning takes place, and referrals for mental health services in the community. These would be referrals before needing to refer to the emergency department. All right. So we talked last week about some of the trainings that are available. The Birch Project training and resources are available on their website and on YouTube. The Maryland Behavioral Health online modules are available. There's forthcoming training at UVA. These are not things that those of you here need to participate on, or really not things that anybody needs to do both of. But a lot of the information covered in the previous Lunch and Learn and today is exactly what's covered here. So these would be more for people in your school communities who didn't get a chance to attend one of these or a conference session and want to kind of get a quick and dirty overview of the process. Also, tier 2 is when you're getting familiar with these steps of the reentry process, which we have talked about. And since this is the time where you're getting the team familiar with it, we're going to go through all of the steps here. So the first part of hospital to school transition is knowing that reentry starts at admission. You would not believe how many school districts and leaders and administrators I've talked to who say once they go to the hospital, like, we don't talk to them, there's nothing we can do, we see them when they come back. And that is probably not the best approach to supporting kids returning to school. You really want to make sure that the parent and guardian feel comfortable and will sign a release of information, hopefully, so that you can get information about the hospitalization. Sometimes they won't sign it, and if they don't sign it, you want to make sure that you have that rapport with them so that they will feel comfortable verbally sharing some details that will be helpful as the child transitions back to school. Also, it's ideal to be able to talk to the folks at the hospital to get an understanding of what they're seeing and what would be helpful for the child's return, particularly if they're finding out information that is relevant to school. So if a child's reporting peer challenges or a challenge with a teacher or something that are impacting their clinical presentation. As I said last time, I've worked in community mental health in schools and in hospitals, and it is so hard to get in contact with folks in the hospital because there are meetings and then individual therapy sessions and family sessions and responding to crises. So if it's possible, always recommend trying to schedule a time to speak with them. And if you just have a non-HIPAA FERPA question, like when a child might be discharged or something of that nature, or scheduling, it's really much easier to try to do that via email. But definitely is hard to maintain contact with them, but can be so important as you start thinking about reentry at admission. While they're in the hospital, or as soon as you find out they're being discharged, that's when it's time to start planning the school reentry meeting. It's recommended that school reentry meetings are held the day after a student is discharged, so that they come to school, have this meeting, and get them right back into the swing of things. In some cases, you'll determine that the child doesn't need to return for the full day. Maybe they need a shortened school day or something of that nature. Maybe they need to go to intensive outpatient first, but typically kids will have the reentry meeting and then return right back to classes. And so it's kind of a little checklist here. The first thing you want to do is schedule that meeting prior to discharge. During that meeting, you want to review what led up to the psychiatric hospitalization, particularly factors that were related to school. You don't always need to know all the home factors and things, but whatever is most relevant to the child's performance at school. Also want to create a safety plan. Often if you're able to get the discharge summary, they will have created a safety plan at the hospital. So that can be a nice starting point, but there will be things that you need to tailor for the school community. Sometimes kids will have on their safety plan going for a walk or taking a cold shower, or things that may not be, that they may not actually be able to do in the school building. Then you want to discuss the students' academic needs, social and emotional needs, and how the school can help meet them. So in terms of academics, developing the makeup plan, their social and emotional needs, if they'll meet with the counselor, or if there's another trusted adult in the school that can check in with them, those types of things. Creating a makeup plan to help the student and the parent guardian understand when missed assignments will be due. Sometimes it's forgiving little assignments. Maybe it's forgiving some of the in-class assignments or forgiving some of the homework, but still requiring the tests and quizzes or paper or larger assignments. Makeup work is often one of the biggest stressors for these kids returning to school. So I always try to express the importance of being flexible, obviously not lowering standards, but kind of making sure that there are reasonable ways that the students can meet the learning objectives in a way that doesn't bring additional stress during an already stressful time. Also designating someone who will check in with the student daily during a designated period. And often people say, like, the school counselor doesn't have time for this, or school psychologist doesn't have time for this. And it doesn't have to be one of them. I was working with some folks from a rural school out in Montana, and they talked about how the school custodian was someone who the kids really connected with. And this custodian was able to check in with a child every day, and they had the time to do it, and they loved it. And it was just something that was mutually beneficial to the child and the custodian. The custodian obviously didn't have details about the hospitalization and kind of what led to it and stuff, but they knew that this child had been out of school, they'd been in the hospital, and just needed a little extra warmth and support, and they were able to provide that. You always hear stories about, like, the school secretary being able to do that, or just these other really amazing people in the school who don't necessarily have a school mental health professional title, but play such an important role in helping kids feel welcomed and loved and supported in schools. Also, this is often a time where we discuss special education status. So is the student appropriately identified? If they already have an IEP in place, are there some additional supports that are needed? If there's not an IEP in place already, likely a 504 plan is warranted, or sometimes this is kind of the impetus for an evaluation for special education. That's always a good time to evaluate during the reentry meeting. And then the caregiver is always provided with a copy of any documentation, including the reentry plan template that I'll share, a safety plan, makeup plan, all of those things. It's also important to include the child in the meeting at some point. If it's a younger child, they may just come in for a few minutes at the end. If it's a high school student, they may be in for most of the meeting. So that's kind of at the school and the caregiver's discretion, but it is important to kind of promote student agency and to have them involved in some aspects of the meeting. This is a school reentry plan template that I created and that I often share. Sometimes I share it with schools and they kind of tailor it to meet their own needs. It draws from a number of different resources that I've had, but basically it's just identifying the child's name, grade, caregiver information, contact information. So you got all of this stuff in one place. It identifies who their school reentry coordinator is. So often for kids who have an IEP, it's their case manager. In some schools, the coordinator is always the school counselor, but whoever that point person is for their return to school, their contact information should be there so that when the parent gets a copy of this, they're able to easily contact them. Also has names and contact information for other folks who might be involved. So if there is a school social worker, or if there is a community clinician from RVHA working with them, you can add all that information there. And then you have if the caregiver signed a release of information or not, if you received a discharge summary or not, the reason for the hospitalization. Next, you identify if the child will return to school for a regular school day, and what the plan for that is. You identify their academic needs, their social and emotional needs, and not just identifying them, but also highlighting who is responsible for making sure those needs are met. So maybe academic needs, the individual classroom teachers are responsible, and who's going to follow up with that and progress monitor, and when are they going to do it? So when will you assess progress? Because you don't want to just do this plan and then never revisit it. Maybe for social emotional needs, it's a school counselor that's going to be checking in with them. Again, you want to make sure you highlight who's in charge and when you're going to assess progress. Might also identify physical needs, IEP needs, or 504, highlighting who will check in with the student daily, who will inform teachers about the hospitalization and the student's needs, and then if needed and desired, who will communicate with peers about the hospitalization. Some children and families don't want that discussed, and they're fine with that. Other children and families experience significant distress around that and do want some help talking to peers about it, especially in the age that we live in. Sometimes kids will have heard rumors or gotten some information on social media, and so if they want help dispelling any rumors or anything around that, it's always important to identify who can provide that support. And then just a space for any additional needs. And I always provide this in a Word document so that it is expandable and you can kind of type right into it. And I don't remember if I shared that with you, Elaine. If I did, you can drop it in the chat. If not, I will drop it in towards the end. All right, and so in terms of the different types of supports that might be needed related to academics, I already mentioned maybe changes to the school day, the makeup work plan, maybe no homework or limited homework or shortening assignments, maybe some alternative grading or extra time on assignments. The list is endless. These are just some of the common academic and instructional support needs for kids after hospitalizations. In terms of mental health support, they might need some case management or maybe the shortened school day again, maybe some built-in breaks throughout the day if they're experiencing significant anxiety or just other things that make the school day overwhelming. Some check-ins with the school counselor or another trusted adult, maybe a modified environment, maybe the cafeteria is stressful for them, or maybe there's something about the class or a particular class, maybe where they've had some challenges with peers. So kind of thinking about what changes might be able to be made to the environment to kind of support their thriving and return to baseline in school. And then also maybe some school counseling services. Again, making sure that they also are receiving some support outside of school, since often kids have been hospitalized, have mental health needs that go beyond what can only be addressed in school. In terms of family support, often caregivers need psychoeducation, connection with local resources, all the things that'll be on your handy dandy resource map. Sometimes they need reminders about follow-up care or help securing that. And then we also need just ongoing communication beyond just the school reentry meeting and that template, but kind of following up to make sure that the plan is being implemented as proposed and that there are no ongoing concerns. And then with that plan, we want to think about how do we know if it's actually working? So we want to see that the child is actually attending school. If they're absent, then we know that something is likely wrong. Also looking at their academic performance. Are things stable? Is it getting better? Are things getting worse? Are they adhering to their treatment recommendations? They go back to the hospital or emergency department, then we know that we need to revisit the plan and see how we can collaborate with their community providers to better meet their needs. We know with our little ones that the school nurse visits may be an indicator of progress. If they're always in the school nurse's office, there's probably a reason for that. They're avoiding the classroom, or they're experiencing some anxiety, got the little belly aches, or whatever the case may be. Also, teacher report and observations can be really important for getting progress updates, as can the students report and their caregiver or even their peers. We often hear from their friends about concerns. So all different ways to consider how progress is being made. Also at tier 2, this is where we do suicide screening and referrals. So the universal screening at tier 1 might identify a child who is having some suicidal thoughts. So then we would do a specific suicide screening and risk assessment, and then make referrals to the appropriate place. So that might include referral to the ED or referral to a community provider from the resource map. So just a few screening tools that I'm not going to go into detail on. I think they're linked on your resource sheet. This one is provided by SAMHSA. It's called the Safety, and helps you look at risk factors, protective factors, asking the questions about suicidal ideation in terms of, do they have a plan, the intent, how often are the thoughts, those types of things, and then helps you to assess risk and determine possible interventions. The Columbia Suicide Severity Rating Scale is another really popular one. And then Signs of Suicide has a screening tool and brief lessons that I mentioned before. The Columbia Suicide Severity Rating Scale has been adapted for use across different contexts. So if you look at their website, you can see a version for use in schools. You can see one that teachers can use, one that peers can use, parents. So it's a really cool tool, and it is evidence-based. One critique, however, though, is that it doesn't, it specifically just gets at if the child is experiencing suicidal ideation or not, but doesn't get into the context or the reasons why. So you can't really use it therapeutically to help try to figure out what's going on or what some of the contributors are. It's just kind of a yes, suicidal, no, not suicidal kind of thing. So if you're finding out based on the Columbia that a child is suicidal, the next step is not sending them right to the emergency department. The next step is doing more of a formal risk assessment and clinical interview to try to get some more information to help you make that determination, or doing that in consultation with other mental health professionals. Safety planning can also be a tier 2 intervention. So you may find out that a child is having some transient suicidal ideation, no intent, no plan, really scary stuff, but doesn't require an emergency department visit at that time. You'd engage in some safety planning. And there are a number of free resources online. These are just a couple examples of safety plans. They often have who the child can go to for help, what are some coping strategies they can use. Not going to go into details on those, but can easily find them online. Happy to share some templates as well. At tier 2 for youth, there are a number of interventions, one being check-in, check-out, super common intervention where someone is literally checking in, checking out with a child each day, providing them with some kind of individual support around a specific issue. Some other small group interventions include bounce back, cognitive behavioral intervention for trauma in schools, or CBITS. Coping CAT is for anxiety, keeping your cool for anger management. Again, you can see none of these are specific for hospital to school transition, but they address common things that may eventually result in hospitalization. At tier 3, this is where we get into the more individualized supports for students. And so it may be providing individual counseling services to students who have significant needs before hospitalization, or providing those or providing those services when they're returning to school after hospitalization. You can also engage in safety planning here, exactly how we talked about at tier 2. This may be when emergency department referral is needed. And then at tier 3, this is when you are implementing that emergency department or hospital to school transition protocol that we learned all about at tier 2. and check-in, check-out could also be used at tier 3. So you see there's a lot of overlap in between the interventions that are used at tier 2 and tier 3, just a bit of nuance in how you use them at each phase. So in terms of individual counseling interventions, just a few that have been found that are evidence-based include attachment-based family therapy, cognitive behavioral therapy for suicide prevention, and dialectical behavioral therapy for adolescents. Most school mental health professionals are not trained in these approaches to implement them in schools. So this is when it's really important to have our community providers who are working in schools that can provide support. There is so dialectical behavioral therapy for adolescents, it's a DBT for short. There's a DBT STEPS curriculum that can be used in schools and is designed to be used by school counselors or other school mental health professionals. But in general, these are evidence-based interventions that we would likely see people with more mental health training implementing. So tier 3 is when you may need to make that recommendation to the emergency department if you do the risk assessment and determine that a child is at imminent risk. As I was highlighting in terms of in my community, there are 3 emergency departments, but really the UVA emergency department is the one that makes the most sense for you. You want to make sure that you are preparing the family. So telling them the best place to go, or giving them options if it is a community where there are different options that they might reasonably consider, letting them know what to expect once they get there, that there may be a long wait, that they may be admitted to the hospital if you're in a community where there is a child inpatient unit, or that they may be transferred. And if they're transferred, they could be anywhere across the state where there's a bed. Often there are ruptures in trust between school and families after an emergency department visit or hospitalization, when they feel that the school set them up or made their child be sent across the state. So it's really important to be kind of upfront with families about the emergency department visit and what those outcomes could be, just to be honest and to maintain the trust and rapport that's already been built. And then as you execute the re-entry process that we discussed, this is exactly what you do in tier 3. You're going through all of these steps and then being sure to follow up and progress monitor. So not going to go through all this again because we've been through them at multiple points. So that is tier 3. Just wanted to note a bit about student voice to improve practice. Dr. Marissa Maricini down at UNC Chapel Hill has been doing a lot of work around hospital to school transition. And I just think that it's important to kind of share a bit of what students are saying. So in terms of re-entry, students kind of think about it in terms of social emotional needs, their academic needs, and then parent engagement. And so you can see that there are a number of different experiences that they have, all things that we've talked about. They have strong emotions upon return. They're concerned about relationships with peers and teachers, worried about what their peers are going to ask them or how they're going to react. They're worried about how it's going to be communicated, how their hospitalization is going to be communicated, who's going to know why they were hospitalized. So these very real concerns that they have. And then they made some recommendations for improving school reintegration. So monitoring them or checking in. So talk about check-in, check-out so much last week and this week. Gradual return is something that they think could be helpful for them. Also support with their work completion, which we talked about with the makeup plan and thinking about what can be forgiven or what can be kind of shortened or made a little bit easier while still meeting those learning goals. They're also looking for connection, communication, and adults in the schools who have a positive approach to engaging with them. And then overall in the school, they want to increase knowledge, mental health literacy, which we talked about at tier 1, increased resources, which I think that we all want in terms of mental health services. And then there were a few things that they reported in another category, but the other ones were kind of the main things. So I always want to share a little bit about kind of student voice and what students are saying and thinking as it relates to hospital to school transition. So now we are going to break into, I guess, maybe 2 breakout rooms. And just want you to do some action planning. I want you to individually think about one practice to implement or strengthen within your organization at tier 1, tier 2, or tier 3, or something you want to share with the school or folks that you work with. So as you identify that thing at each tier, I want you to think about the strengths that exist within your organization and potential barriers to implementation. And then in your groups, you're going to share out and engage in some collaborative problem solving. And then when we come back together, I want you to identify one strength that stood out to you that someone shared, and then one particularly challenging barrier that we can discuss as a group. And so we'll take 10 minutes in those 2 breakout rooms. So, all right, well, welcome back. I'd love to hear from each group one particular strength that stood out that someone shared. Welcome back, Dougie. I was just noticing that you had dropped off. So welcome back. I'd love to hear kind of one strength that stood out to you, and then one particular challenge that stood out from each of the pairs.
I'll speak from my group. We identified a strength from our agency is having the therapeutic day treatment in a lot of the schools for Richmond City. It allows for the TDT case managers to be in the school sites on a daily basis. So they're able to build those relationships as far as the students, the admin staff, the principals, the guidance counselors, everyone there. Where as far as a community-based mental health, although we have those, it's not as direct, or we have to go through loopholes sometimes to get a hold of some of those. And TDT has those providers right there in the school. We have clinicians who are able to provide outpatient therapy, and also to do intakes at the school sites sometimes to directly link them to additional services. So I think that's been definitely been a very beneficial avenue for us.
Nice, thank you. Anybody want to share a particular challenge or barrier that we've been trying to overcome?
One of the more recent barriers, like Sheree said, it's been great. We've been trying to eliminate barriers. We have them at the school site. They can do intakes there. But previously with COVID, they could do an intake via Zoom. Regulations have changed, and now they have to be in person. And so it just depends on the kiddo scenario. If they're a completely new case, they have to go downtown to our office location with their parent for the intake. And so what we're finding in some of these instances here recently, they're not making it downtown as scheduled, even though you don't need an appointment. But if they said, hey, I'm going to go on Wednesday or Thursday, they're not making it. And even in some cases, for the ones that are scheduled to take place at the school site, we're not capturing some of those. We're having to reschedule those. But when we had it via Zoom, it was much more convenient for the parents to access services.
Yeah, I've heard that across the board, just not being able to provide Zoom or virtual services has been quite a challenge. I hope that with more advocacy, we can get some of those like policies related to insurance and things changed to increase access to care for children and families.
And another strength I want to add is that previously the outpatient was taking place at RBHA, but within the past year, we've been doing that via Zoom. So some of our TDT kiddos are actually getting outpatient also during the day, maybe once per week or once bi-weekly. bi-monthly with a clinician at RBHA, but via Zoom at their school.
Is that a challenge, you said?
No, a strength.
Okay, a strength. Okay, cool.
Mhm.
Awesome. Yeah, that's an awesome one. Great. Thank you so much for highlighting that. All right. So I hope that it was helpful for you all. Maybe you learned something that you can use in your organization that was a strength, or maybe you're able to come up with some ways to address barriers together. I know that Zoom intake stuff is difficult because it's above us and more like policy procedure type things, but hopefully there was something that you took away that was helpful in that action planning. Got some resources here. Some of them are the same as last week. Kind of the school reentry guidelines website, the training modules, the SHAPE system you can review for universal screening. Resources. The Center for School Mental Health also has a resource mapping guide if you wanted some of those templates or wanted to do more related to that activity. Also, the VDOE has a suicide prevention guide or some resources on their website. All of these resources are on the handout that Elaine shared. If there is something that's not on there, please feel free to reach out to me and I'm happy to share whatever. My contact information is on the bottom of those handouts. Just a few references and then a few minutes for Q&A if there are any outstanding questions. Happy to answer. You all have my email address and I'm happy to answer any future questions or provide future consultation. I hope that this has been helpful for you all. I enjoyed sharing this content a few weeks ago and today. So thank you all for being here.